Hello, everyone. I'm Noor, and I am proud to present you multiple sclerosis today. So it's a broad topic, but before starting, I wanted to put it in a couple of sentences. So our summary is first, we're going to talk about what is MS, and then we're going to talk about why do we really care about MS this much. Then we will try to understand how a possible MS patient can present to your office and how can we actually diagnose someone with MS. After that, we're going to talk a little bit about the phases and phenotypes, and lastly, pathophysiology and of MS. And there are two main points I want to make throughout the presentation. First one is MS is a spectrum of diseases rather than just a single diagnosis. And my second point will be MS is more than just the lesions we see on MRI. So before starting anything, I wanted to give you a couple of disclaimers. So like I said before, multiple sclerosis is a very broad topic, too broad to just be covered in 20 minutes. So I will be oversimplifying things, and my main goal is to put more questions into your minds rather than answering every single one of them. But hopefully it will be a good presentation for you guys. So let's start. If we understand the sentence that you see on your screens, you understood at least 20% of multiple sclerosis, basically. So multiple sclerosis is an autoimmune condition that affects central nervous system. And this sentence teaches us four things. One, it's an autoimmune condition, so meaning immune cells attack self. And in this case, they attack myelin keys. Second thing is it directly affects central nervous system and not peripheral nervous system, but it can affect every inch of central nervous system or brain and spinal cord. And actually, the last 2 points come directly from the name of the disease. So, sclerosis means lesions where healthy tissue is exchanged for interstitial tissue for some reason or another. And they're permanent, they're always there, they're just going to accumulate in time. And like I said, our fourth point is also hidden in the name. There are always multiple lesions in this disease. So with that knowledge, let's talk about why do we really care about multiple sclerosis? Because it is usually seen in young people, women with reproductive age, and it is the most disabling neurological disease of the young adults. And actually, we now have treatments for it. So currently, our patients have less disability than MS patients in 1990s. So if diagnosed well and managed well, patients have better prognosis with these medications. That is why it is very important for us to be able to understand multiple sclerosis cases. And since this is a disease of central nervous system, and central nervous system does everything in our body, the presentations can really vary. But there are some common presentations, usually depending on the lesion location, and they are like vision loss due to an optic neuritis. If a lesion is in cerebellum or brainstem, there can be vertigo, there can be ataxia. If the lesion is in spinal cord, there can be paralysis, there can be sensation changes like shooting pains. If somehow again lesion is in sacral part of the spinal cord, there can be neurogenic bladder. But besides these lesion location related presentations, there are also a couple of presentations which I find very interesting. We see them in almost all cases, and they are usually not related to lesions. They're always there. And they are mood changes, especially depression. There are cognitive fog, cognitive decline, and lastly, fatigue. Almost every single MS patient has fatigue. So you have a patient that you suspect from MS, walked into your office. Then what you're going to do? First, like every single one of us do, you're going to take a good history. But in this case, you're going to take a great history of relapses. How did it start? Was there anything triggering? Are there any progression? Progression meaning steady decline of neurological function. If there are things like that, how many times in the past did the patient experience relapses? So on and so forth. And we have two important phenomenon we usually see in demyelinating disease. And it really doesn't mean that the patient for sure has MS, but it definitely helps us diagnosing the case. They're Uthoff's and Lermit phenomenon. So Uthoff phenomenon is basically when a patient's core temperature increases. It can be due to hot weather, hot showers. It can be due to extreme exercises. The patient suddenly feels themselves weak, and every single dysfunction they had in the past becomes exaggerated. And Lermit's phenomenon is when we do neck flexion, neck hyperflexion, there's an electrical sensation going down our spine. And like I said, these are usually signs of central nervous system being overactivated or overheated. So they're very specific to demyelinating disease, and they can help us with the diagnosis. Like I said in the past slide, fatigue is almost there, and it is usually debilitating for many patients. Many patients get retired because they cannot focus on anything or cannot really get out of the bed. So it is an important point to question. And lastly, in history taking, I believe questioning if the patient has any pursuit of being pregnant in the near future is important for especially women of reproductive age, because many of our MS medications are contraindicated in pregnancy, but we also have medications that are safe in pregnancy, so we can make that decision accordingly. After our history taking, we're going to do a physical examination, and multiple sclerosis physical examination needs to include every single part of the neurological examination, basically, because we can see abnormality in all of the, or any of the parts of neurological examination. From tip to toe, you have to examine the patient. And after this encounter, or if you still think this case is possibly multiple sclerosis, you need to acquire MRI. In the past, people were less prone to acquire MRIs because basically it was harder to acquire. But since now we have the chance, if a patient doesn't have a contraindication for MRI, we definitely should acquire that. And we have different sequences that tells different things, but I'm not going to go into detail about that. And if you collected enough data right now, you can stop right there and give the patient MS diagnosis. But if you still need supporting evidence, you can go with CSF assessment or lumbar puncture. And there are a couple of keywords that leads you to multiple sclerosis, and they are increased IgG index, presence of oligoclonal bands, increased white blood cell count. And newly, we have a new term called, or new concept we use in multiple sclerosis called neurofilament light chain. It is still not routine, it's very pricey, but it basically shows nervous system damage that happens in a relapse. So that can be a good count or measuring tool to keep in mind for future. And lastly, we have specific tests for different parts of our nervous system. We can check optic nerves, we can check spinal cord damage, we can check brainstem damage through evoked potential tests. And after that, we have a data. We have a set of data. And the thing you see on the screen right now is the diagnostic criteria. It renews once in every 5 to 6 years. The new edition is on the way. And this criteria doesn't aim to exactly diagnose multiple sclerosis. It just tries to diagnose multiple sclerosis as early as possible and as efficiently as possible. So, for instance, if you diagnose someone with MS, and after a while, if a better diagnosis came up, you can change the diagnosis. It's not a set in stone diagnosis, but it helps with us. It helps us to start correct medications, basically. So we have diagnosed someone with MS. Now we're gonna explain them their prognosis or how they're gonna experience this disease. And right now, there are basically 2 phases. So now I have a small animation. Let's say we have a lovely patient, and Jay, she's wonderful. She doesn't have any inflammation going on in her nervous system. She doesn't have any symptoms, but that doesn't mean that she has genetic mutations or environmental factors that makes her more prone to MS. And at that phase, we call Jane MS-prone individual. And if she develops lesions, if she develops inflammation in her nervous system, but if she's asymptomatic, we call her radiologically isolated syndrome or RIS. And if, I mean, there's a threshold that our brains can endure. And after a while, an attack will happen, a clinical symptom will occur, which we call relapse. And then now we're going to call her clinically isolated syndrome. Clinically isolated syndrome includes only one attack. And if multiple attacks starts occurring, basically, we're going to call her relapsing remitting MS. And, all right. And if she starts developing a progressive worsening of the neurological symptoms, then she entered progressive phase. And since she had relapses in the beginning, we're going to call her secondary progressive MS. But all I wanted to show you is that it is a continuous spectrum, and relapses and progression is not mutually exclusive. The patient can still have relapses and progressive phases. It's just rarer than in relapsing remitting phase. Again, let's say Jane, again, she's an MS-prone individual, and she, again, developed inflammation but doesn't show any symptoms. We again call her radiologically isolated syndrome, but she directly started having progressive decline rather than relapses. Now we call her primary progressive MS because the disease course started with progression, so it's primarily progressive. And this is a easier, I think, graph. Again, we have relapsing remitting. There are relapses, there are recovery periods. We have secondary progressive. There were relapses in the past. The patient starts recovering. The patient starts progressing, but the patient goes on progressing no matter what. And primary progressive is the patient progresses no matter what you do. You only try to slow the process. And I love this figure. I'm not going to go into the detail, but what I love about this figure is you can put every single patient with inflammatory activity in their brain somewhere in here, basically. If they have MS pathophysiology going on in their brain, they're going to find some place or some diagnosis in this table, which I love. So this further emphasizes that MS is actually a spectrum or a combination of diagnoses. But all of these combination of diseases occur due to same pathophysiology, which brings us to pathophysiology of multiple sclerosis. So basically, again, I want to disclaim that I'm going to oversimplify everything, and none of them are set in stone. They can change in the future because known is little compared to unknown in this territory. So we have a brain, and there are a bunch of processes going on brain, but I classified them in three groups. First, we have lesions, as we all expect, and we have damages done due to these lesions. We have also atrophy going on every single part of the brain. It can be cerebellum, it can be deep gray matter, especially thalamus, it can be cortical gray, it can be white matter. But this is going on not related to lesions. So they go atrophied on their own, with or without lesions. And the third category is the damages done to normal appearing white matter. I love the term normal appearing white matter because it tells you that it is not normal. There's something pathological going on in there. And I will talk more about it in a minute. But first, I want to explain the balance of relapses and progression. So why someone decides to go on progression at some point? Because multiple sclerosis has two components. One is inflammation and the other one is neurodegeneration or neuron death. And we have both of these components in every single part of the disease. But in the beginning, inflammation tends to predominate, and towards the end, neurodegeneration tends to predominate. And when inflammation is dominating, there's relapses. And when neurodegeneration is dominating, there's progression. So this is always a balance, and whichever side the balance is disturbed, we're going to see that side's symptoms more. And so after we're done with relapses and progression, I want to talk a little bit about the journey of lesion formation in multiple sclerosis. And I love the analogy of a floorboard. For instance, a floorboard of a house can endure a weight of 70 kilogram individual, right? But if this floorboard is infested by termites, let's say, the floorboard will still look healthy on the outside. But as soon as someone steps in the floor, there's going to be a dent or there's going to be a lesion in this matter. So, but us not seeing any lesions on the MRI doesn't mean that this white matter is completely healthy. And after a while, so this is active lesion, and there's only, this is only a focus where inflammation is increased. And after a while, there's not going to be any more myelin at the center to be eaten by the immune cells. So the inflammation will continue from the rims. And at the end, even that will be done, or we will give the patients immunosuppressants so that immune cells are not activated anymore. And then at the end, we see an inactive or a silent or a chronic lesion. And these tend to persist. For instance, the lesions of anti-MOG disease tends to go back to normal after a couple of years. But in MS, you only accumulate lesions, not get rid of lesions at all. And I mean, this is my last slide. Normal appearing white matter was the main thing I wanted to explain today about pathophysiology, but I find it really interesting because these two articles, combined with our previous literature knowledge, kind of gives you the idea that yes, we do non-focal symptoms in patients like fatigue, like cognitive disturbances, like depression. And we can go ahead and say that it's merely related to chronicity of the disease or the progression of the disease, so on and so forth. But these articles also ties them to the disease process in the entire brain rather than just lesions. So in MS, I always think it like, and the whole presentation is my mind map, how I understand topics as a first-time reader. So how I imagine MS brain is constantly on the edge, and it is trying its best, basically, but any sort of push will push it that out of the edge. So it's going to give us symptoms. It's going to give us fatigue, cognitive fog, so on and so forth. So MS brain is constantly fatigued, constantly on the edge brain, basically. That is why patients are feeling worse than they should have, basically, according to their clinical presentations, according to objective science we see. And with that, I came to the end of my presentation, and I can take any questions. Thank you.
Okay. Thank you.